Welcome to AETCM, the Emergency Medicine channel. Welcome to the series of EM Rapid 2022. Today we will be discussing about digoxin, beta blocker and calcium channel blocker toxicities. First, digoxin toxicity. Digoxin inhibits the sodium-potassium ATPase, resulting in an increased intracellular sodium and extracellular potassium. As a result, the sodium-calcium antibody is not able to effectively remove the calcium from the myocytes, leading to increased intracellular calcium and hence improving the ionotropy. The increased intracellular calcium leads to delayed after depolarizations, causing premature ventricular contractions and arrhythmia. And there is also a delayed refractory period of the myocardium, leading to increased automaticity, leading the chances of arrhythmia. So coming to diagnosis, the diagnosis of digoxin toxicity depends on the history, the physical examination and lab studies. The therapeutic dose is 125 to 250 microgram and the toxic dose is 1 to 2 milligram per dose, and fatalities occur at doses like 10 milligram single ingestion. So what are the differential diagnoses of digoxin toxicity? So digoxin toxicity, the patient will be presenting like having bradycardia or AV blocks and all. So in similar presentation will be seen in patients on CCB, like having a CCB toxicity, beta blocker overdose, class 1A antiarrhythmic, class 1C antiarrhythmic, clonidine, and OP or carbamate poisoning. So these are the differential diagnoses of digoxin toxicity. The clinical features of digoxin toxicity. The clinical presentation is different for acute toxicity and chronic toxicity. Acute toxicity will be seen in patients having an accidental or deliberate ingestion of a large digoxin dose, and chronic toxicity will be seen in patients on digoxin therapy developing a renal dysfunction or like along with that having a diuretic use and all, and in such patients there will be like a chronic toxicity. So the symptoms will be, there will be GI side effects like nausea, vomiting, abdominal pain and anorexia that will be seen in both acute and chronic. Then the CNS effects will be headache, dizziness, confusion, coma and all in acute, and in chronic toxicity there will be fatigue, confusion, delirium and coma. And cardiac effects, there will be bradyarrhythmias or supraventricular tachyarrhythmias with AV block in acute toxicity. And chronic toxicity, there can be any ventricular or supraventricular arrhythmia, and ventricular arrhythmias are more common. The electrolyte abnormality associated with acute toxicity is hyperkalemia, but in chronic toxicity, the hyperkalemia may not be seen. There can be a normal or reduced potassium level. And the serum digoxin level is of use in acute toxicity where it can be elevated. But in chronic toxicity, though the patient will be having toxic features, the patient's digoxin level may be within the therapeutic range. The ECG changes known as the digoxin effect is seen in all patients like who are on therapeutic dose of digoxin. So the digoxin effect include E-wave changes like flattening or inversions, QT shortening, scooped appearance of the ST segment with ST segment depression known as the reverse tick sign or Salvador DALI moustache sign. And there can be an increase in the U-wave amplitude. So the ECG changes seen in digoxin toxicity are features suggestive of an increased automaticity and decreased AV conduction. So there can be supraventricular tachycardia, slow ventricular response, sinus bradycardia, frequent VPCs, slow AF with complete heart block, then ventricular tachycardia which can be a polymorphic and bidirectional. So mostly like if a patient having AF is on digoxin and developing a toxicity, patient may be presenting with a regularization of the atrial fibrillation. That's a slow AF with a regular rhythm may be seen in a patient having AF on digoxin with developing a toxicity because of the development of a complete heart block. So these are the ECG findings seen in a digoxin toxicity, which is showing a polymorphic bidirectional ventricular tachycardia. And this is the Salvador DALI moustache sign or the scooped appearance of the ST segment, which is also known as the digoxin effect. So the lab tests that we have to do are potassium levels and the digoxin level. The potassium level is of very importance in acute toxicity because there can be associated hyperkalemia, which will further worsen the arrhythmias. And digoxin level is of use in the again in the acute toxicity because in chronic toxicity, serum digoxin levels may be normal. The therapeutic range, these are the serum digoxin levels. So therapeutic range is 0.5 to 2 nanogram per ml, and the toxic range is more than 2.5 nanogram per ml. And as already told, serum digoxin level is not the sole factor in establishing digoxin toxicity as a diagnosis. And similarly, like certain other substances like foxglove, digitalis glycosides, then oleander and lily of the valley, all these plants, the plant derivative glycosides, cross-react with the digoxin serum assay. So there can be a immunoreactive substance cross-react, and these toxins also will be showing positive result to serum digoxin level assay. So coming to the treatment. The treatment in like any toxicological presentation or any toxicological ingestion, the treatment basically it includes the general treatment and the maintaining the ABCDE. So the general treatment like include cardiac monitoring, getting an IV access, then frequent re-evaluations and all, and like maintaining the airway breathing circulation. That is like the important in all the toxicological presentation. So here like digoxin toxicity, patient will be presenting with some arrhythmias. So there will be like life-threatening arrhythmias. It should be like managed, and simultaneously we have to look for any other cause or any other factor worsening the arrhythmia, like hypoxia, electrolyte abnormality, hypovolemia or anything, and we have to address that as well. And coming to the decontamination part, GI decontamination is like of use in like acute ingestions, and activated charcoal can be given at a dose of like a 50 mg or like 1 mg per kg dose of activated charcoal can be used in an early presentation. And the specific treatment in digoxin toxicity is that digoxin specific antibody fragment, which is like seen in a brands like Digibind and all. So the indication is a patient with digoxin toxicity having a life-threatening arrhythmia and hyperkalemia with a potassium level of more than 5 milliequivalent per liter. And what are side effects we have to anticipate while giving the digoxin specific antibody fragment are the patient will be on digoxin for its inotropic effect. So suddenly we are giving the antibody fragment, patient may develop the cardiogenic shock because of the lowering level of the digoxin. And other thing is patient can develop hypokalemia and also hypersensitivity reactions. So here is the dosage calculation of the digoxin antibody fragment. So based on like the digoxin serum concentration, it is like the digoxin body load equal to serum digoxin concentration into 5.6 liter per kg into weight in kilogram by 1000. And each vial of digoxin antibody is about 40 milligrams, and it neutralizes 0.5 milligram of digoxin ingested. So we have to calculate it accordingly. Each vial will be 40 milligram. It will neutralize 0.5 mg of the digoxin ingested. Other formula based on the total serum digoxin concentration is number of vials equal to serum concentration in nanogram per ml into patient weight in kilogram by 100. So it is another formula of calculating how much vials of digoxin is required. So the acute poisoning reversal, digoxin, like each vial of digoxin, I have already told it reverse 0.5 milligram of ingested digoxin, and half the calculated dose will be initially infused. If the patient is not responding, we can give the other half dose in like after 1 to 2 hours. And if we are not aware of how much the dose the patient has ingested and we don't have a serum concentration available, we can go for like a treatment of 10 vial. As an initial in treatment. And if the patient is like going into cardiac arrest, we can bolus it. If the infusion, we can give it over 30 minutes. But if the patient is going into cardiac arrest, we can give it as a bolus. So in chronic toxicity, the calculated dose, half of it is administered, and if the patient is developing any instability, we can give the other half. Usually in chronic toxicity, around like 1 to 3 vials of digoxin specific antibody fragments will be required in reversing the toxic effect. And we have to admit the patient to an ICU, monitor for like a minimum of 6 to 12 hours, and we should be keeping the patient on continuous cardiac monitoring, and the patient's serum potassium levels should also be monitored. So here it is a quick overview of the digoxin toxicity. The general treatment is the same. Then only thing is, like, if the patient is developing bradyarrhythmia, we have to go according to the bradyarrhythmia protocol. We can give atropine, like 1 mg IV can be given. And by the time, like, if we are suspecting digoxin toxicity based on the findings or the history or the digoxin level, we can arrange for the digoxin specific antibody. And till that time, we can bridge the gap. We can bridge the like therapy by giving atropine and also going for a temporary pacing, that we can go for a transcutaneous pacing. Then now coming to the beta blocker toxicity. So beta blocker toxicity, the beta blockers will be acting on the beta receptors. So commonly seen beta receptors are 3, beta 1, 2 and 3. And beta 1 is seen in myocardium, kidney, eye, and beta 2 in the bronchial, visceral, smooth muscles, skeletal muscles, vascular tissues, and beta 3 in the skeletal muscles and adipose tissue. So basically, the beta blockers, the action of beta blockers is that the beta receptors will be there, and the beta receptor, when it gets activated, will convert ATP into CAMP, which will activate the phosphokinase, and it will phosphorylate the calcium channels, leading to the calcium influx, and this calcium binds to ryanodin receptors, and the when calcium binds to ryanodin receptors, the calcium stored in the sarcoplasmic reticulum will be given out, and this calcium will bind to the muscle spindles. The actin myosin complex will be formed, and hence the cycle is complete. This is how the beta receptor action is there. So in beta blocker, this beta action gets cut, and as a result, the proper cardiac contraction and all won't be taking place. So there are certain pharmacological properties of beta blockers that defines its toxicological properties. So these are the beta 1 selectivity, the sodium channel blockade, the lipid solubility, the protein binding, and its partial agonist activity. So basically, in beta blocker toxicity, the symptomatology as well as treatment depends on certain other factors. These are the drug formulation, that is whether it is a regular preparation or an extended release preparation. If it is an extended release preparation, the symptom onset will be delayed, and we can go for other measures like multiple dose activated charcoal and all in the treatment. So extended release formulation, we have to monitor the patient for a prolonged time because the symptom onset will be delayed. Next is the rate of drug absorption. Rate of drug absorption depends on any co-ingestion the patient has taken or any other pre-existing pathological condition of the patient that will delay the absorption. So in such conditions, the patient's presentation will again be delayed because of the delayed rate of absorption. And another thing is protein binding. If the patient, if the drug the patient has overdosed is having a high protein binding, it is difficult to remove it by techniques like hemodialysis and all. Other one is lipid solubility. So certain drugs having a high lipid solubility will be crossing the blood-brain barrier, and it will have some central effects as well. And such drugs we can in treatment we can go for treatments like IV lipid emulsion and all in drugs having high lipid solubility. And other thing is the elimination. If it is basically by hepatic elimination. So in patients having any liver dysfunction and all, the elimination will be delayed and hence prolonging the toxicological effect. And last one is the volume of distribution. So drugs basically having a high volume of distribution again is difficult to be eliminated. So the symptomatology and treatment of beta blocker toxicity depends on these pharmacological properties of the drugs that has been ingested. So the basic clinical features of beta blocker toxicity include hypotension, bradycardia, conduction blocks, ventricular arrhythmias, mostly associated in drugs like sotalol because of its added potassium channel blockade. Then asystole can be there, decreased contractility will be there. Then patient can have depressed mental status, coma, psychosis, seizure, and respiratory arrest. It is commonly seen in drugs like propranolol, which has a high lipid solubility, making it cross the blood-brain barrier and cause these central effects. And there can be bronchospasm, and associated electrolyte abnormalities commonly seen are hypoglycemia and hyperkalemia. Diagnosis, again, it is based on history, physical examination, and certain specific lab tests. And lab testing, like apart from the specific drug level, we have to look for the glucose levels, the oxygenation, basic acid-base status of the patient, and any renal or hepatic dysfunction if present. And in specific drug level testing and all, basically in any toxicological presentation having like a low sensorium or altered mentation and all those things, we'll be going for a routine toxicological sedative and other drug screening panel. So in a urinary screening such panel, if the patient has ingested labetalol, there is a chance of a false positive report for an amphetamine screen, because one of the byproducts of labetalol metabolism is very much similar to amphetamine. So the false positive urine amphetamine screen can be seen in a labetalol ingestion. Then other things in a diagnosis, we have to go for proper ECG monitoring. ECG will be mostly showing a bradycardia associated with other AV blocks, and a Brugada-like pattern can be seen in a propranolol overdosage because of its sodium channel blockade property. So, like the differential diagnosis of beta blocker toxicity include other drug overdosages presenting with the bradycardia and hypotension. So, these drugs include calcium channel blockers, digoxin, the other digoxin like glycosides, class 1C antiarrhythmics, clonidine, cyanide, and organophosphates. So, how we will be differentiating these from beta blocker toxicity is because each toxicology ingestion will have a toxidrome. So, if CCB, there will be associated elevated lactic acid and hyperglycemia. In digitalis or digoxin toxicity, there will be hyperkalemia, ventricular ectopics will be there, and we can detect the drug in the digoxin immunoassay. And in class 1C antiarrhythmics, there will be bicomplex tachycardia. Clonidine, patient will be having opioid-like manifestations, coma, meiosis, respiratory depression, and all those will be there. Cyanide, there will be metabolic acidosis and lactic acidosis associated with that. And in OP poisoning, there will be the muscarinic toxidromes. So coming to the treatment, again, airway breathing circulation and the general management, which include the cardiac monitoring, ECG, bedside echo, and the hemodynamic monitoring. And in beta blocker toxicity, we'll be administering some specific drugs or specific treatment. So, how long we should administer the specific treatment? What is the end point of our treatment? That we should know. So, we'll be targeting a cardiac ejection fraction of 50% or more, the QRS interval reduction to less than 120 millisecond. We will be targeting a heart rate of 50 to 60 beats per minute, then a systolic BP of more than 90 to 100 millimeters of mercury, and a urine output of 1 to 2 ml per kg per hour. So in GI decontamination, again, activated charcoal is useful in extended release formulation ingestion or in a very early presentation. And in patients having a large ingestion of extended release formulation, whole bowel irrigation is also helpful. But important dictum regarding GI decontamination is that we are going for a GI decontamination and the patient is having an altered mentation or a low sensorium such that the patient cannot maintain the airway, we should go for a definitive airway, or we have to go for a intubation before proceeding with the GI decontamination. Otherwise, there is a high chance of patient developing aspiration and other complications. So this is the pharmacological treatment in a nutshell. Basically, beta blocker toxicity, if the patient is having hypotension, along with that, if it is a prolonged QRS more than 120 millisecond, we can go for sodium bicarbonate. If there is associated decreased contractility, we can go for glucagon, high-dose insulin, adrenergic agents, and calcium salt. If there is a decreased systemic vascular resistance, we have to go for vasopressor, and bradycardia, we have to go for glucagon, adrenergic agents, and cardiac pacing. So for specific treatment, first line specific treatment in the management of beta blocker toxicity for bradycardia and hypotension is glucagon. Glucagon acts by independent activation of the myocardial adenylate cyclase bypassing the impaired beta receptor. So there will be increased CAMP caused by the glucagon bypassing the impaired beta receptor. So its effect will be in 1 to 2 minutes and peaks in 5 to 7 minutes, and the duration of action will be for 10 to 15 minutes. So short duration of action will be requiring a bolus followed by a infusion. The bolus dose is 3 to 10 milligram, and if the effect is not seen, we can repeat the bolus after 10 to 15 minutes, and we can follow it by an infusion at the rate of 1 to 5 milligram per hour. The side effects commonly seen is nausea and vomiting. Adrenergic receptor agonists, norepinephrine, dopamine, epinephrine, isoproterenol, all can be used, and all this can be used in preventing the bradycardia and hypotension, or the treatment of bradycardia and hypotension. Other specific treatment is high-dose insulin therapy. It is also known as hyperinsulinemia euglycemia therapy. Basically, here insulin acts as an ionotrope by facilitating the myocardial utilization of glucose. So, at the time of stress, the glucose available for utilization for the myocardium will be depleted. So, this insulin, along with high-dose insulin, along with glucose, it will help the myocardium in utilizing glucose as a source of energy. So this is the basic protocol for high-dose insulin therapy in beta blocker overdose. We will have to check the blood glucose level. If it is less than 200 milligram, we will have to give a bolus of 50 ml of 50% dextrose in adults and 1 ml per kg, 25% dextrose in children, followed by 1 unit per kg IV bolus of insulin. And along with that, we'll have to start the patient on an insulin infusion 0.5 to 1 unit per kg. Simultaneously, we'll have to start the patient on a 10% dextrose infusion at the rate of around 200 ml per hour. Then we have to titrate the insulin and the dextrose infusion so as to reach our target regarding the hemodynamics. We have to reach the target, and we have to check the GRBS every 15 to 20 minutes and maintain it between 100 to 200. Simultaneously, we have to adjust the insulin dose also, and we have to check for the potassium levels. The potassium should be kept between 2.8 to 3.2 milliequivalents per liter, and if it is coming down, we have to supplement it as well. Next specific treatment is the IV lipid emulsion therapy. So it is also known as the fat emulsion therapy or the lipid rescue therapy. Here the IV lipid emulsion will be acting as a pharmacological sink, and it will basically cause sequestration of the lipophilic drugs into separate lipid compartment, and so the amount of free drug available to the receptor or the target tissue is reduced. Other mechanism of IV lipid emulsion is providing the myocardium with free fatty acids and phospholipids. Its dosage is 20% lipid emulsion, 1.5 ml per kg bolus over 1 minute, followed by an infusion at 0.25 ml per kg. We can repeat the bolus if there is no improvement, and we can increase the rates of infusion by 0.5 ml per kg per minute, and the maximum dose is not more than 10 ml per kg over the initial 30 minutes. The side effects are lipemia, will alter the lab values, and there can be hypertriglyceridemia, acute lung injury, acute renal failure, pancreatitis, DVT, and cardiac arrest. Next drug is atropine. Atropine is the drug of choice for any bradycardia. We can give atropine 1 mg IV. Then calcium. So calcium therapy basically reverses the depression of the myocardium via positive ionotropic effect. So in patients with refractory shock, we can go for calcium salt administration. We can go for 10% calcium gluconate, 0.6 ml per kg over 5 to 10 minutes, followed by an infusion at the rate of 0.6 to 1.5 ml per kg per hour. And during this, we have to monitor the ionized calcium. The side effect is pain at the site of infusion and soft tissue necrosis, and there can be hypercalcemia, conduction block, and worsening bradycardia also. Next is phosphodiesterase inhibitor. Milrinone is a phosphodiesterase inhibitor used in treatment of calcium channel blocker. beta blocker toxicity. Again, if there is a prolonged QRS, wide QRS arrhythmia associated with beta blocker toxicity due to a sodium channel blockade, we can go for sodium bicarbonate therapy. 2 to 3 milliequivalent per kg IV bolus can be given over 1 to 2 minutes or followed by an infusion. Then if there is like a persistent bradycardia, we can go for both internal or external pacing. And it is most beneficial in sotalol toxicity. Other methods like hemodialysis, then in a refractory shock, cardiogenic shock, we can go for ECMO and intra-aortic balloon pumps. So next, coming to calcium channel blocker toxicity. Calcium channel blocker toxicity is very similar to beta blocker toxicity in its presentation and treatment. Basically, CCBs act to the alpha units of L-type calcium channel, reducing the calcium entry, resulting in reduced cardiac automaticity, weakened cardiac contraction, and intracardiac conduction delay. Again, diagnosis depends on history, ECG findings, signs of bradycardia, varying degrees of AV block, and slowing of the intraventricular conduction. There can be associated hyperglycemia and lactic acidosis due to systemic hypoperfusion. The DEDs are, apart from the toxicological causes, other differential diagnoses of calcium channel blocker toxicity are hypothermia, ACS, hyperkalemia, hypothyroidism, and other toxicological drugs we have already discussed. Treatment, general treatment, airway breathing circulation. If there is altered mentation, rule out other causes of altered mentation like hypoglycemia or co-ingestion, and we can again go for a GI decontamination, activated charcoal in early presentation or in extended release formulation. Calcium salts are the specific treatment of choice. So basically, calcium chloride is preferred over calcium gluconate because 3 doses of calcium gluconate will be equivalent to 1 dose of calcium chloride. But the issue is that while giving calcium chloride, there is high chance of thrombophlebitis and pain at the site. So preferably, calcium chloride should be administered through a central line. So the dose is 10 ml of 10% solution calcium chloride, which will be like equivalent to 1 gram, will be given over 5 minutes. It can be repeated every 10 to 20 minutes, and infusion at the rate of 2 to 6 gram per hour can also be used. Calcium levels should be monitored and it should be kept at 1.5 to 2 times the normal. Other drugs like adrenergic agents, norepinephrine, epinephrine can be used to maintain a MAP of 65 millimeters of mercury. Here also we can go for high dose insulin therapy. The protocol is similar to that has been discussed in the beta blocker toxicity. Again, glucagon can be used. Theoretically, glucagon will be acting the action of glucagon will be at the beta receptor, and calcium channel blocker will be causing a blockade downstream the site of glucagon action. But in practice, glucagon administration has shown improvement in the hemodynamic status. So dose is 5 mg bolus in adults over 1 to 2 minutes, followed by an infusion of 5 mg per kg per hour. Then again, intravenous lipid emulsion can be used, which will act as a pharmacological sink. Here also the dose is 1.5 ml per kg lipid emulsion bolus, followed by 0.25 ml per kg per minute infusion. And we can repeat the dose if the BP is still remaining low. Other measures like ECMO, intra-aortic balloon pump, and left ventricular assist devices can also be used. And other thing we have to keep in mind is that the extended release formulations will be having a delayed presentation. So we have to keep the patient under monitoring for 6 to 24 hours minimum, because there can be a delayed presentation in extended release formulation. So this was regarding the digoxin, beta blocker, and calcium channel blocker toxicity. Hope you all have got some idea on these three topics. Thank you.